And let's move to the next chapter where we will deal with congenital urological disease. We're now on vignette number 7. You are called to the nursery to see an otherwise healthy-looking newborn boy because he has not urinated in the first 24 hours of life. Physical examination shows a big, distended urinary bladder. This is not normal. I'm sure one of the options that would appear in a question like this on the exam would be reassure the parents the kid doesn't need to pee until tomorrow. That's not true. That might apply to passing meconium, but not to urine. And so something is wrong with this child. The first thing you ought to do here is look at the meatus, because meatal stenosis is one of the things that could do this. If that's not the case, then we're probably dealing with posterior urethral valves. To diagnose that, we drain the bladder with a catheter. The catheter, in fact, can be passed because the valves would not prevent the catheter from going in. They are oriented in such a way they prevent the urine from going out. And then we do a voiding cystourethrogram for diagnosis, and then endoscopic fulguration or resection of the valves for the treatment. Let's move to vignette number 8. A bunch of newborn boys are lined up in the nursery for you to do circumcisions. You notice that one of them has a urethral opening in the ventral side of the penis, about midway down the shaft. This is hypospadias, a fairly common congenital anomaly. But the point of this vignette is that you do not do that circumcision, because that skin you were going to remove and throw away is going to be needed for the plastic reconstruction with which that urethra will be rechannelized to go back, to the proper place. So don't do the circumcision. Now, for year number 9, we had mentioned this when we were reviewing urological trauma. Let's mention it again. A 7-year-old child falls off a jungle gym and has minor abrasions and contusions. When checked by his pediatrician, a urinalysis shows microhematuria. Remember, we had said if an adult has big trauma, and then we find a few traces of blood in his urine, we don't get too excited about that, because we know that with big significant trauma you can have a little blood in the urine. But a child with insignificant trauma, this child was not in a car accident at 100 miles an hour, he fell from a jungle gym. In a child with very minor trauma, when we find that there is blood in the urine, we worry about a congenital anomaly. And we do a urological workup. And a good way to begin a urological workup on a child, the safest way, is sonogram. We may later need to do other things, but a sonogram would be your next move. We now go to vignette 10. A 9-year-old boy gives a history of 3 days of burning and urination, with frequency, low abdominal and perineal pain, left flank pain, and fever and chills. This is not a common thing. We do not expect a little boy to get a urinary tract infection like we expect a young woman of reproductive age to get bladder infections. There has to be something here to explain it, and the most likely thing, given all the symptoms here, is probably reflux. In other words, what this sounds like, and we are trying to demonstrate, is that every time that bladder contracts, some of the urine shoots up back in the direction of the kidney because there is reflux. And so you obviously will treat the infection the child has, but for these, the IVP and the portion of the IVP called a voiding cystogram is your best test. A sonogram alone will not show you the reflux. And so with a dye in the bladder that got there by way of the intravenous pyelogram, we ask the child to urinate while pictures are being taken, and we see the urine going back up into the ureter. If we find that, typically then the management after that is simply to protect the child with antibiotics for the infections that he's getting, and sort of, quote, let him grow out of the problem. Let me explain what I'm talking about. The reason most people do not reflux when they void is that the implantation of a ureter in the bladder occurs at an angle whereby there is a portion of a ureter within the wall of the bladder. When the bladder contracts to empty, that segment of the ureter gets shut off by the contraction. What this child has is essentially a straight implantation of a ureter into the bladder. It doesn't have the normal angle straight. But as the child grows and the bladder gets bigger, the inside point on that bladder and junction with the ureter remains where it is. The outside part of that gets moved up and up and up with the growth, and eventually what was a straight implantation becomes an angled implantation with a segment of ureter that's within the wall. And so it is not necessary to operate all of these children. We can allow some of them to hopefully grow out of a problem. We now move to vignette number 11. This is such a classical presentation that my friends who practice urology in children tell me they can make this diagnosis over the telephone. They hear the description, they know what's wrong. Let me read the vignette. A mother brings her 6-year-old girl to you because, quote, she has failed miserably to get proper toilet training. On questioning, you find out that the little girl perceives normally the sensation of having to void and voids normally and at appropriate intervals, but also happens to be wet with urine all the time. Here is what's going on. This little girl has one ureter implanted normally into the bladder. That ureter fills the bladder, the girl goes through the normal process of urination. But the other ureter has a low implantation into the vagina, beyond the sphincter. The other ureter then leaks urine all the time. So the little girl voids in a normal way at the same time that she's wet all the time. Physical examination alone may be able to give you the answer. You may be able to see the opening of the ureter in the vagina just dripping the urine. And if not, an IVP will show it to you. The IVP is good to show exactly where the ureters go, how many ureters we have and where do they go. And then a surgical reimplantation, of course, would take care of the problem. And the next vignette is equally typical in terms of the description. And again, my friends who are pediatric urologists tell me they can diagnose it over the telephone. Vignette number 12. A 16-year-old boy goes on a beer drinking binge for the first time in his life. Shortly thereafter, he develops colicky flank pain. This youngster has ureteropelvic junction obstruction. Let's talk about that. As the name implies, there is a very narrow place where the renal pelvis and the ureter join. There is enough lumen through that kink there for the normal flow of urine to get by. So the first 16 years of the life of this youngster have been asymptomatic as far as that is concerned. But a strong stimulation for diuresis would result in big flow that can no longer flow to that tiny little place. And you know that beer is a very strong stimulant for diuresis. So the first time in the life of this youngster that he goes out drinking beer, he has horrible flank pain, colicky pain, because the ureter and the pelvic junction cannot handle that flow of urine. My friends in the field tell me this phone call always comes at about 11 p.m. Doctor, we're so sorry to bother you. Little Johnny is screaming in pain. He's got this flank pain. It hurts when he tries to urinate. And so the urologist asked the family, did little Johnny by any chance go out drinking beer? And the answer will be, oh, doctor, we're so sorry to tell you. He's a good boy. He had never done that. But yes, today his older brother took him out with his friends. And there is a story. Well, a very good way to begin the workup here would be a sonogram. Remember, sonogram is very safe. Sonogram is widely used in pediatric urology. And sonogram is excellent at showing obstruction. And so the sonogram will show you the big dilated renal pelvis, and then surgical correction of the anomaly will take care of it. Now that takes us then to a picture or two. Here is a picture of vesicoureteral reflux. This one was actually done by means of retrograde catheterization, because you see that there is a catheter that goes in through which the dye has been injected. But this is how we would diagnose. This is a type of picture that we use to diagnose vesicoureteral reflux. It could be done as part of an IVP also. And that takes us to the end of the congenital urological diseases.